for Dagenham Central PCN. I'm an educator for both F2s and ST1s.
Hi, I'm Sandeep. I'm one of the GP registrars. I'm from Willow's Medical Practice. And I've done a few of these lecture series. You might have seen me if you've attended other talks. We're now on our third tier for CKD. So hopefully we can do some changes and we can apply some knowledge in this webinar.
Oh, Manpreet, you're mute.
Hi, sorry about that. My name is Manpreet Saini. I'm the practice pharmacist working at the Willow's Medical Practice alongside Dr. Singh and Dr. Shoaib.
I'm Dr. Sun Hussain. I'm a GP. It's lovely to see so many people here. I can see we've got a few people from the last webinar as well. Lovely to see you all. I hope you enjoyed today's webinar.
And hi, I'm G, the health and wellbeing coach, supporting the educators from a personalised role perspective.
Wonderful. Thank you so much. Shall I start presenting?
Yes, please. So, as I'm sure you guys are aware, today's webinar is going to be about the monitoring and management of CKD. If we move on to the next slide. Obviously, we've done the introduction. So the aim of it is first, obviously, if we to successfully know how to manage and diagnose CKD, we need to first understand what is CKD, why is CKD so important. Then we're going to talk a little bit about in terms of what we can do for the management of CKD, what we're doing to help improve early detection, and then personalized care role in CKD. That's the aims of today. Move on to the next slide. Okay, so what is CKD? So CKD obviously stands for chronic kidney disease. It's defined as a reduction in the kidney function or structural damage, or both, present for more than 3 months, with associated health implications. So the important factor being here is that it is actually the 3-month time limit that we have in here. So we have to have like essentially an EGFR, which is below kind of that threshold of 60 for more than 3 months to kind of come into the classification of CKD. And it's really important that we don't forget this, because prior to that 3 months, everything should be considered an AKI until proven otherwise. Chronic kidney disease is in itself, obviously, as the name suggests, a long-term condition which affects the way in which the kidneys work. It is unfortunately an irreversible process, but it doesn't mean we can't help reduce the rate at which that loss occurs by the appropriate, early detection and appropriate management. It's a common condition within the population. A significant proportion of the population have it, and the current consensus is that at the moment we're quite heavily underdiagnosing this problem, and therefore there is obviously a lot of a drive to try and help improve diagnostic rates for patients. And the reason that's important is that the vast majority of patients have quite a mild version of the condition, but it can progress to quite a serious condition with significant complications, notably the total kidney failure and patients needing to kind of resort towards dialysis. It is also, obviously, in terms of age correlation, it is significantly more common in the elderly population. So as we age, obviously, we're losing our nephrons continuously, and therefore we're more likely to suffer from CKD in the latter ages of life. Yes, next slide. Okay, so in terms of, obviously, how do we diagnose CKD? So as I mentioned before, we need to have 2 parameters separated by at least 3 months in time. So that would be an EGFR of less than 60, the presence of protein in the urine, or known structural disease. Obviously, with the polycystic kidneys and things like that, you're not going to necessarily need to repeat that same investigation in 3 months' time, but people who've got polycystic kidney disease will obviously be considered under having chronic kidney disease. Next slide. So in terms of the classification of CKD, I won't talk too much in terms of the management, but of this, which I think one of my colleagues will address in some of the later slides. But essentially, the classification of CKD traditionally was done on the G1 to G5 scale. So we would have said G1, G2 are normal, G3A onwards, we would classify patients as CKD and code them as having CKD. And obviously, this is just a progressive decline in our EGFR. Now, we actually use a dual metric, or we should be using a dual metric to assess patients in terms of CKD, and that's looking to see for the presence of, trace proteins in the urine. And hence why we do urine ACR to kind of look to see how much protein there is present in the urine, and we use that to then put an A score. So obviously no or very minimal protein present would be A1. A moderate amount of protein is A2, and then quite a significant amount of protein in the urine would be A3. And we can collate this to give people like a score of like a G1 A1 or a G1 A3. And as you can see, traditionally, if we just followed the G, the staging, like stage 1, stage 2, and used EGFR, we're not going to see any. We're not going to detect or do anything differently for people in G1 and G2. But with the presence of protein in the urine, you could actually you may be more concerned for the patients, even though they may have preserved EGFR. Next slide, and I will hand over to Sandeep.
Hi, thank you. I was just trying to answer some of the questions on the chat. So there's around 3 million people or so in England, I think, that have CKD. So Yasmin, if you just click along the slide. So this is a question I want to give out to everyone. Why is it important to monitor and treat early onset CKD? I'm currently covering for Dr. Sherib, who unfortunately couldn't make it today because of an emergency. So I'm just going to cover her slides. You'll hear me talk for quite a bit now. So this is the first question. If everyone can just put it into the chat, or I'm even happy if anyone wants to say it through the mic, it's fine, but it's probably easier through the chat. So if you just put the number in the chat from 1 to 4, why does everyone think it's very important to pick up on CKD early and monitor that? Is it to prevent the rate of progression towards dialysis, to prevent hematuria, to prevent the development of squamous cell carcinoma, or is it to get down on preventing resistant hypertension? So I'll wait for everyone to put it down in the chat. After I got a few responses, we'll move on. Excellent. So I'm seeing the general answer being number 1. I can see some people are saying all of the above, and in fact, you're not wrong, because all of these will start to contribute towards a later stage. But Yasmin, if you click next on the slide. So now if you see what's happening, if you see what's happening in the slide, you can see that in this part in particular, you can see this is sorry about this. Just got something on my. So essentially, the answer number 1. It's progression towards ending up on dialysis. You can see that chronic kidney disease is a progressive disease. It's going to end up getting to the point where your nephrons are not functioning well enough. But what we aim to do is pick up this early to prevent the rate of progression. And essentially, this is the pathway that ends up happening. And you can see on the right-hand screen, which is a hemodialysis machine, it's the end stage result. So if you click next, please. So excellent. So can everyone just type into the chat complications of CKD that you've come across in your practice? I'm just going to have a look at the chat and see what everyone has dealt with. Any difficult situations that you've dealt with CKD, you've thought this is potentially due to CKD, whether it's electrolyte abnormalities or anything else. I'm going to wait for you guys to answer in the chat. Okay. Brilliant. Okay. Excellent. So everyone's mentioning quite a lot of complications that can happen. So if you click next on the slide, please. And again, and one more time. Brilliant. And one more time. Excellent. That's it. So here you can see, the vast array of complications that CKD can cause. You can see protein leak from the proteinuria, susceptibility to infections, blood clots, edema, dysregulation of your calcium phosphate system, affecting your parathyroid glands, increased risk of strokes, heart failure and heart attacks, build up on unwanted proteins causing amyloidosis, affecting your heart and also, localized areas of joints like inducing carpal tunnel syndrome. You can see it can affect the bone and cause dystrophy, osteodystrophy, increased amount of lethargy and tiredness, resistant hypertension, issues with drug filtration, and toxicity, in fact, because of reduced excretion and also the need and requirement of transfusions for marked anemia. Next, please. And again, so can everyone type what type of dialysis they know? I'm looking for everyone to tell me the two most common types of dialysis that everyone is aware of. If you just type it in the chat. So it's interesting that we often don't see these patients, but maybe there's a telephone consultation that happens, because a lot of these times that patients that are on dialysis usually do have a very good renal team that they can call directly, or that's constantly monitoring, catering for them. But it may be a chance that you may see a patient with dialysis. So if you click next, please. So thank you. Everyone's completely right. There's peritoneal dialysis and hemodialysis. And Yasmin, if you just click along the screen, we're going to get some pop-ups coming up. So the main aim of the dialysis is essentially it's acting like a kidney. They're going to filter out all the fluid and electrolytes. Either it's going to happen outside the body. So you've got the outside kidney, which is the hemodialysis, or you've got the inside kidney, which is the peritoneal dialysis. Now, the reasons patients usually get referred to this is because they've got very low eGFR, the symptoms are marked, or it's because they went into acute admissions in the hospital and it turned out that they're no longer able to filter out the blood and the urine output has completely stopped. So they vary a lot of the time. Hemodialysis normally will always happen in the hospital. Some patients do have home hemodialysis. Commonly, peritoneal dialysis is the one for home. The difference between them is one, you have to do 3 to 4 times a week, which is the hemodialysis. And you can imagine your patients 4 hours every about 4 times a week. That's 16 hours a week that they're in the hospital just having dialysis. And the other hand is patients that have peritoneal dialysis, which is at home. And there's different types that they can have. Either they have a machine that they carry with them and they exchange this dialysis solution 3 to 4 times a day, or they have one overnight and they leave it for 7 to 10 hours and then they carry on with the day-to-day activity. If you click next, one important thing to note is that, if you could click back, please. One important thing to note is that dialysis, the process for it takes a very long time. Especially for example, hemodialysis, getting a fistula ready takes about 3 months. So that's something to be aware about when you have patients that are waiting to be started on dialysis. Just look out for the complications and be aware whether they are on potassium binders, be on the lookout if they develop acute shortness of breath. Although they should be managed directly by the renal colleagues and secondary care, if they are discharged while waiting for all of the fistula to become patent and ready, be aware that these complications can arise. Next, please. And again. Okay, so name key areas that are treated in CKD. We're now going to cover management areas. We discussed a lot of this in the tier 2 talk, so I'm not going to go through everything that's been discussed. Rather, I want you all to tell me and answer the questions that I'm going to pose through the case study. So the first thing is just put into the chat all the different areas that you cover in your clinics for a patient that's got CKD. You've gone onto your patient list, you've seen on the alerts, you've gone to the investigations, you can see that they've got a low eGFR and they've got lots of other complications that are happening at the same time. Maybe they've got anemia, maybe they've got other problems. What are you going to be tackling? What are you looking out in your primary care clinic to tackle for CKD patients? So we've got the anemia, electrolytes, fluid balance. Excellent. What else? Medication review. Perfect. All right. Just waiting for some more responses on what you all do. BP review, unis, meds, calcium checks, anemia. Perfect. Excellent. So Yasmin, if you click next on the slide and refer to nephrologists, hopefully that's not the first thing that we want to do. But yeah, that's definitely something that we do want to look at towards. So if you click next, if you click along the slides, and again, so these are the mainstay areas that we try to review, along with medication review, which I haven't added a picture of, but definitely medication review is definitely a key thing to look out for. And our pharmacy colleagues can do a medication recon to look through everything and ensure that patients are on optimized medications for the CKD level. But this is essentially what we want to tackle: blood pressure, sugar control, protein leak, anemia, cardiovascular atherosclerosis risk, and also bone mineral disease. Just click next. So I've got a case study now. You've got a 64-year-old patient booked with the nurse for a health check. The nurse has noted there's a large blood pressure around 164/84. She's done it 3 times, and patients come with some documented blood pressures that resemble the same value, and it's spanned over about 3 days. The nurse has done the blood test, she's done the urine test, now she's booked in with the GP. So if you click next, Yasmina, for me. Okay. So you see, you're going to see in clinic, and you learn that she's essentially taking ancilla, sertraline, and also has severe back pain and is on regular amitriptyline. Click next. So the blood test that you record from her previous practice, because she is indeed a new patient, is you can see she's got EGFR of 48, she's got creatinine of 92, potassium of 4.8, and also sodium of 138. So you already think, okay, I can see a CKD level, she's around stage 3. So if you click next, and again. So you've now got this patient in your clinic, and you've got the up-to-date blood test. You've been doing a telephone consult. She's there in person. You've got these blood results. You can see that her EGFR is still around 46, showing that she's a stage 3 CKD. You can see that the potassium, sodium, creatinine are stable. Next. And again. So I've actually told everyone this. If everyone can look at the side, nobody needs to really remember how to stage it. We always have this classification with us. So you can see over here that she fits the 45 to 55 criteria that goes to the stage 3A. So if you click next, so everyone tell me which one would you use to treat the patient? So you've got an option of calcium channel blocker, losartan, ramipril, atenolol, and indapamide. So on your chat, just write down the number that you would choose to treat this patient's hypertension. So far, this is all the information you have at the moment. You've got nothing else. You don't have any. So there's a question about proteinuria, which is a good question, but we don't have that yet. So we've just got this so far. Okay, so a lot of people would want to go straight for the losartan and ramipril, and that is a good idea, because essentially we are all going to be thinking that this patient's going to develop complications of proteinuria. So if you click next, so actually the best, if you go back, please. So the best medication at this stage, with the information that we have at the moment, on the assumption that there is no proteinuria, would be amlodipine. You'd follow the normal hypertension guidelines, because what we're trying to preserve is renal, it's essentially renal perfusion. And hypertension can essentially cause deterioration in renal perfusion, which can lead to microvascular damage and damage to kidneys and cause chronic progression of that CKD. So anything, to be honest, can be used. In this current case study, without any proteinuria, we would choose amlodipine. However, if you decide to go for losartan and ramipril, you wouldn't be wrong either. But if we follow the guidance, it would be amlodipine at this stage. Click next. And again. So now you've got a urine protein result, and you can see her urinary ACR is 42. And again, if we go to the classification, we can see now she's at a G3A A2 CKD grade. So if you click next, please. And again. So now everyone's already answered this, essentially, but now would be the time where you would want to put this patient on ramipril or losartan, because you know they've got proteinuria. So sometimes when you have a patient that's got CKD and you don't have the urinary protein, you can hold off on managing the hypertension, unless, of course, it's very high, until you get a urine protein. When you have the results, if it's a normal urinary ACR, they don't necessarily need to be on ramipril or losartan, because ramipril essentially just dilates the afferent artery of the renal tubule, which causes reduction in intraglomerular pressure, hence reducing proteinuria. That's the mechanism that it's involved. But if they've got no protein leak, then they don't need that added afferent arterial dilatation. You can manage with just normal hypertension guidelines. So click next, please. And again. So this is another thing. When you have patients on ACE inhibitors, you want to make sure that you start them from the lowest dose if they've got CKDs. You don't want to rush them to giving them 5 milligrams, 10 milligrams. Start with the lowest dose and increment slowly. Next. And I added this as well because one thing you want to remember is that some of these patients fit the criteria of requiring an SGL2 for renal protection because they've got CKD, they've got proteinuria. Now the next stage is adding on the SGL2 for renal protection. Next, please. All right, again, next. So you've uptitrated your patient to 5 milligrams. You've done it in a very slow way. You put it on 1.25, you got them to 2.5, and then you went straight up to 5. You made sure that you were checking the UNEs. Now, the 4-week post-UNE of the 5 milligram titer has shown an eGFR 44, which is fine, but potassium is quite high. It's around 5.8. So if you click next, please. So the first thing you want to think about, what could be causing this hyperkalemia? So everyone in the chat, just write down the reasons why you think this patient could have hyperkalemia. Okay, Ramipril. Okay. And when you say Ramipril, what do you mean Ramipril? Are you talking specifically that it's affecting a pre-existing condition, or are you saying it's just secondary to the medication itself, or is it due to the CKD stage? What is it because? Okay, so click next. For me, great answers in the chat. So I thought it was due to hemolysis. So I had the bloods repeated, and it's been confirmed to be 5.7. So now we've got repeated blood, which is showing chronic hyperkalemia in this stage. What would everyone do? So this is your patient in your clinic. You've seen that they've got hyperkalemia. You repeated the blood, and it's still raised. What are you going to do now? So again, just put it in the chat. I'm following through. So you would stop it. So some people would stop it. Some people would withhold Ramipril. Okay. Okay. So generally, it seems that everyone's going to hold off from the ACE completely. Ah, excellent. Okay, that's a good idea. All right, so click next. So there's a very good answer. So essentially what you can do is you don't need to hold off and stop the Ramipril completely. What you can do is you can reduce it to the previous tolerated dose. So if the patient was doing quite well on 2.5 milligram, go back to 2.5 milligrams. If the blood pressure is a problem and you're not just using it for proteinuria, you can add on amlodipine or other antihypertensives, definitely. So click next for me, please. So essentially, that's what I did. I reduced the Ramipril to 2.5 milligram. I repeated the potassium, and it came back after a week to 5.3. And I thought that was good. We managed to put the patient on a tolerated dose. So everyone forgot to mention one thing. So click next for me, Asmina. And the fact that the patient has back pain, and that was mentioned, that this patient regularly uses amitriptyline for back pain and has a stock of naproxen PRN. So it could have just been that she just started using naproxen during that period of time when we uptitrated her Ramipril. So that's something to bear in mind, that other medications, that despite the fact that they're just on PRN, or sometimes patients have a stock of them, just to be aware of other causes. And I think somebody very early on wrote medication. And it is a good idea also to consider doing ultrasounds in patients that once given Ramipril develop an eGFR reduction of 25%, because what you're trying to query is whether they've got renal stenosis. And the reason that's affected is because if you open up the efferent arteriole, you cause, it's an imbalance that happens because Ramipril prefers dilating the efferent arteriole. And when you dilate that part of the glomerular, the afferent arteria has disinhibited constriction, and that's what causes you to have reduced renal blood flow and causes you to get an AKI or CKD in these patients. And that's when you query it's renal stenosis. So next, please. So we've covered this before in the tier 2 talk, so it's just for everyone to take back when you watch through the videos. These are the guidelines on what we use and how we manage the patients that are either diabetic, non-diabetic with proteinuria, or non-diabetic with very minimal proteinuria. So next, please. All right, so another case study. So here we have a 72-year-old male He's got CKD stage 4A2. He's come in because of lightheadedness and he had his recent bloods checked. So you notice that he's got EGFR of 28, which is stable. He's got a proteinuria of 28 and his HbA1c has decreased from 110 to 84. He's on this collection of medication, as you can see. And one of the things that's been happening is he's been having a lot of erratic blood sugars. So if you press next, so you can see his blood sugars vary a lot from 3 to 17. So press next for me. What would everyone do? Are you going to make any medication changes? Is there anything you're going to do for this patient? Is there any other queries that you're having for the lightheadedness? Yasmina, please do let me know when it's approaching around 10 to 15 minutes because I want the other speakers to also have time.
Okay.
So you want to try SGL2? Okay, wonderful. Or someone's written metformin, but I'm not entirely sure what you mean. You want to increase metformin, you want to decrease it, you want to check blood pressure. Yeah, excellent. So blood pressure is normal in this patient. They've got a blood pressure that's around 115 over 80. Okay, perfect. So if you click next for me, Yasmina. So definitely you want to stop the metformin. The EGFR is not tolerating it. All you're doing is predisposing the kidneys to go into lactic acidosis. There's no need to continue that metformin at this stage. The second thing is you need to start thinking about other medications, how they're responding at this stage. The kidneys EGFR is very low. How well are they actually filtering out the glycoside? Is the glycoside dose too high? So one of the options that you could have, actually, if you click next, Yasmina, is you can reduce the glycoside, but then you're going to be worried about the HbA1c. It's quite high and progression of diabetic nephropathy. So you want to get better control. So if you click next, so the other 20 milligrams, you can either replace it with a gliptin. You can think about a GLP-1 inhibitor, although we don't have any anymore. Or you can add on, or you can just decide, let me get rid of all of the glycoside and put them on insulin, a very low basal and bolus regimen with good glucose monitoring. So for this particular patient, I reduced the glycoside and I added on sitagliptin. If you click next, there was a mention about this, so we'll go straight to it, about SGL2 inhibitors. So you need to bear in mind that when your renal function is less than 45, you're not actually going to add towards diabetic control. It is good to have this patient on an SGL2 and they fit the criteria for it, but you need to bear in mind it's not going to help with diabetic control. Less than 45, you're not going to get much change in your HbA1c. Next, please. All right, just go next. So here's another case. You have a 40-year-old female who's a renal transplant patient. She weighs around 70 kilograms. CKD stage with her new renal allograft is stage 3B/A2. And you can see her EGFR and urinary ACR. She had bloods done recently because she was feeling very lethargic. And you notice that the new blood shows a HbA1c that's 120. So these are her medications. You can see that she's on ramipril already, prednisolone and tacrolimus for her allograft. She's on diazepam, lansoprazole, aspirin, atorvastatin. So what is this diagnosis? You've got this sudden HbA1c of 120. And just to make it a bit more realistic, this is a patient that perhaps was away from the country for maybe 2 years and has come back. So stop metformin, SGL2 add, and prednisolone. Okay. Anything else? Anyone else have any suggestions? All right. All right. Click next for me, Yasmina, please. And again. Oh, brilliant. Yes, insulin. So this is type 2 diabetes in this patient, and we've got a range of options. We can use SGL2, metformin, glycoside, GLP-1, and insulin, but which one will actually work and help in this patient? Not all of them. So click next for me. The first thing I did for this patient is I checked the ketones because I was very worried why all of a sudden they've got this raised HbA1c. And I wanted to make sure that it wasn't anything like diabetic ketoacidosis. And we should not forget about hyperosmolar hyperglycemic state that can happen quite commonly in type 2 diabetics. It's very difficult to pick up just by doing observations of parametrics. It's actually seeing the patient yourself. If they're very, very unwell with a very high sugar, send them to A&E. They need to have treatment done for it. So click next for me. If your patient isn't that severely unwell, you've got a few options. And I think the safest one in this patient would be starting them on insulin, a basal bolus regimen. Click next. And this is something that you can consider. I put the weight in there because often how you would try to manage someone that's got transplant renal dysfunction is by timing the body weight by 0.3, getting the daily overall insulin use. You divide it by 2 by getting the basal rate, which is going to be 10, and divide the other one by 3 for each of the bolus ones. So if you click next again from me. Next. So if you're not comfortable using insulin, you can use a low-dose glycoside to try and bring down that HbA1c. Next. And again. So once your HbA1c starts to go less than 90, you've done a rescue for them and you can consider other options. And a lot of the time you want to make sure whatever medications you're giving to renal transplant patients, you're in touch with the primary renal team because they're very protective. And you know this all the way through clinical years of medical school, that they're very protective of the renal transplant patients. You want to make sure that you've got the diabetic nurse or a medical on-call team involved in the first instance when it happens, depending on how severely unwell the patient is. Next. So SGLT2s don't really have much of, there's not much data on their benefits in renal allografts. We don't really know how well they work with patients that have got transplant, how good they are on patients that have got, essentially, we're not sure how well they contribute to the renal protective nature in renal transplant patients. There are a couple of randomized controlled trials that have been done and they show there are some benefits, but we don't have anything that's solidified this data for us to use it. So it really does matter. It would really much depend on what the renal physician that's looking after them decides, because currently I don't think there's enough concrete data for us to start using them in renal transplant patients. Next. And again. Okay, so this is just an overview of all the oral hypoglycemics that we spoke about in tier 2. Next. And again. So that's just about the SGLT2s that we discussed. This is just the framework of the proteinuria. All of these were discussed in tier 2, so I'm not going to go over it again. And I will present this last case study now, and then I will hand over to my colleague. You're right. HbA1c is not, it's never going to be sudden. It's a gradual increase that's happened, but the patient, I'm just referring to the question in the chat. If she has just come back to the country, high HbA1c may not be sudden. That's absolutely correct. It is a gradual increase that's happened, and they've just never seen the doctor for over 2-3 years. And that's what happened. So if we go through this last case study, if you click next for me. Yasmina, do I have time to go through this case study, or shall I hand over to my colleagues?
It is 505, sorry, 405.
So, okay, I'll briefly go through it quite quickly then.
Okay.
So you've got 82-year-old patient that's got tiredness and bone pain. You can see the blood results in front of you. If you click next through if you click next again. Yep, perfect. And again. So essentially what I'm highlighting here is that you've got 2 parameters that fit the criteria. This patient has got low EGFR, less than 30. They've got clear anemia in the blood results, and they've got low vitamin D. You don't commonly test for vitamin D unless they're around stage 4, stage 5, because that's when the conversion to the 1,2,5 dihydroxylase isn't working efficiently, and that's when you would normally test these patients. If you click next for me. And again. So this is the management I proposed for this patient who had a low vitamin D and also anemia. I started them on ferrous fumarate. I actually put them on every other day because they had complaints about constipation. So I tried to lower that risk of, not so much risk, but lower the incidence of their constipation by giving them ferrous fumarate every other day. And they had laxative support already. Cholecalciferol, you can do different types of loading. There's a guideline on North Central London pathways that recommends using cholecalciferol 20,000 units once a week. Next, please. And again. So if you don't get much in terms of symptoms or in terms of improvement of the anemia with ferrous fumarate, refer them for iron transfusion. Once you've got their ferritin to the above normal limit, which is around 100, and they're still symptomatic or anemic, you then refer them for EPO treatment. If the vitamin D has been completely reloaded and it's completely normal, but they're still having a lot of symptoms, having a lot of bone pain, you refer them to the renal team to start them on alpha calcidol to obtain a shared care plan management, because it requires crucial monitoring because of risk of hypercalcemia and hyperphosphatemia. Next, please. So this is just the guidelines about how you identify anemia in a CKD patient and how you treat them, which we covered in tier 2. Next. And this is the mineral bone disease and the different parameters that you should be testing in someone that's CKD stage 4 or 5. Next. And again, this is just the treatment pathways and how to tackle different electrolyte abnormalities, be it vitamin D, calcium, or phosphate. Next. And next again. That's all. This has all been covered in tier 2, so I won't go through it again. So I tried to put in some case studies. Hope that was useful. I'm going to hand over to my colleague, Mr. Saini, the clinical pharmacist, to continue this on when it's important to refer patients in that have chronic kidney disease. Thank you very much.
Okay. Right. Hi everyone. Right. So thanks a lot, Sandeep, for that. So as you can see, there's a lot. I mean, when we think kidneys, we are thinking of all the it's pretty much it's pretty much a whole syndrome it is. So it's not just simply a case of thinking about the EGFR or creatinine clearance and things like that. However, there are times when we would need to actually refer the patient. I'm just going to give you a couple of seconds maybe just to put in the chat about what are your ideas about when would you actually refer a patient for or when would you actually refer the patient to the renal team, or when would you certainly seek advice? So if people want to put that into the chat. Okay, don't have anything, not getting anything at the moment from yourselves, but yeah, refractory anemia and deterioration of the EGFR, yeah, absolutely. Anything further? Yeah, as soon as CKD is detected. Okay, fine, fair enough. I'm just wondering, when you say as soon as CKD is detected, are you talking about at what EGFR level are you speaking when you say CKD? Okay, I'm guessing you probably mean less when it's less than 60, stage 4 or 5. Yeah, absolutely. So the thing is, there are obviously, I mean, there are times when we need to think about, okay, when is it a case of that we need to start worrying that this patient, okay, is developing CKD, or there's been a sudden change in the GFR, the CKD stages, really, the staging of it. So we really do need to start thinking about things like that. So to begin with, one of the things that is there in the guidelines is the fact that you could start by going by the EGFR. So for a start, usually if you find that the EGFR is less than 15, usually it will require an immediate referral to the renal team, because obviously at this point you might be they are nearing their end stage, and they may well need to, going forward, once it deteriorates a little bit further, they may well need to start thinking about dialysis, so it's renal replacement therapy. Usually, so that's usually when it's below 15. During the point where it's 15 to 29, usually they may require referral to renal services as well. There might need to be some discussion as well with regards to that. However, as we're going to around about 30 to 59, HFL 30 to 59, one of the things that you would need to take a look at, and I do tend to see it's there on the slides, one of the things that I do tend to see is that there might be the percentage change in the GFR, which we need to think about as well. So usually it's a case of if it's 25%, 25% or more, and in the last 12 months that change has caused a change in the GFR category, you may well need to think about doing the referrals at that point as well. Other times, or it could be, for example, if the GFR there's a decrease in over 15 mils per minute in the GFR within 12 months. Again, it's a good idea to get the renal team involved, or at least seek advice to see what would happen next. You may need to also think about doing that referral if other things, you see other things such as unexplained microcytic hematuria, so something which is not necessarily visible. If proteinuria as well, if the ACR is, that's when the ACR is over 70 or the PCR is over 100 milligrams per millimoles. Or for example, I tend to think of this as with the word, the mnemonic in my head is PACK, PACK. So if they have an abnormal phosphate, abnormal anemia, which is inexplicable, calcium and potassium, the KB, the potassium. So anything like that, you may need to refer for specialist services. And if, however, usually when it's above 60, I mean, remember, once upon a time we used to not get told anything was wrong until it was less than 60. We just need to have this cut-off point of over 60, but now they've included it for 90 as well. So usually when it's 60 plus, usually you don't need to worry too much about referrals unless there's, we're thinking about there being any genetic diagnosis or any other reasons or any urinary abnormalities, or you've just noticed that there is a sustained decrease in the GFR from the 90 down to the 60. You might need to think about what's going on. You might need to maybe consider repeat blood tests or even an ultrasound of the kidneys to find out exactly what's going on, any stenosis, so on and so forth. With things like acute kidney injury, that would require an immediate referral. Usually, if it's stage 1, they do tend to think about repeating the blood tests again in around about 72 hours. But an acute kidney injury, you may need to think about immediate referral and discussion as well. Routine referral will be if the, as I said, if you had proteinuria, as I mentioned above previously, or if the ACR is is over 30, or the PCR is over 50, and you've got your microscopic hematuria as well, that's your invisible hematuria, you might need to consider a referral there. Other urgent referrals would include heavy proteinuria, where your serum albumin is actually low as well. That could be something what is termed as a nephrotic syndrome, and or if by any chance you're thinking about the fact that there's a rapidly progressive renal impairment, as I mentioned earlier, you would need to think about doing urgent referrals then. Also, if you think about hematuria as well, if you're thinking if there's visible hematuria, but you tested them for the UTI, they don't seem to have any UTIs, and there's just and with things such as the ACR or even the blood, there is a lot of suggestion there that this patient does actually have renal disease. Again, think about doing that referral as well. When it comes to things like hypertension, obviously, we've seen many times about when people have hypertension, you need to worry about things like target organ damage. So once again, a routine referral is necessary if the blood pressure is over 150/90, and the patient happens to be on 4 therapeutic agents, hasn't made much of a difference. So you may would need to think about target organ damage, and therefore you may require an immediate referral, especially if it is malignant hypertension. And also with regards to if there's any systemic illness, for example, we've mentioned a few things already, but things like vasculitis, sarcoidosis, myeloma, for example, that might require an urgent referral as well, or at least a discussion as well. If there's an outflow obstruction as well, usually you would think about going to a urologist for things like that. However, if you are getting things like your symptomatic uremia, you're getting your hyperkalemia, as I mentioned, the high potassium or fluid overload, think about doing that referral as well. One of the things that my colleague also he showed this slide, but he didn't necessarily talk about, is about about managing patients. So one mnemonic that I also use is the alpha mnemonic, where you may need to consider for them to be on statins, at least 20 milligrams of statins, because you want to try to lower the cholesterol, at least a 40% reduction in the cholesterol. Think about lifestyle as well, weight reduction, and also smoking cessation as well. Because proteinuria, that's when you start thinking of your ACEs and your ACEs and your ARBs, in order to, because we're aiming for renal protection at this point. There's the SGLT2s, the gliflozins. There's more evidence stacking up about how they can be quite renal protective with patients with CKD as well. And especially, and more so, you need to think about if the patient happens to be diabetic as well. We've already mentioned hypertension as well, and anemia, managing the anemia as well. So that's all from myself at the moment.
I think if we just move on to my slide, if that's all right, Yasmina, which is the improving early detection. Keep going, you're almost there. There we are. Brilliant. Okay, so sorry about that, guys. So, as Anna said, I'm just really going to be talking about improving the early detection of CKD and why it's important, and also how we can get the multidisciplinary team involved at an early stage. Some of the material is duplicated from Tier 2, so apologies to those who are attending both, but I'm hoping those who have attended Tier 2 have perhaps had some thoughts about involving members of their multidisciplinary team, and if anyone has any ideas or want to ask any questions, then now is the time. And we've also got G on hand, who can also perhaps offer some ideas or answer any questions for us as well. So as we know, CKD is increasingly common. There was a question in the chat about prevalence, and I think somebody said there's about 3 million people in the UK, and I think I also thought it's about 6.1% prevalence. So it's quite a vast number, and actually about 1 in 1,000 people tend to progress to needing dialysis or a renal transplant, and we heard quite a lot about what dialysis involves. So it's really something we want to try and avoid. And the difficulty with CKD, of course, is that it's largely asymptomatic in its early stages. And that really feeds into why it's important for us to recognise who's at risk of CKD. It facilitates the screening of these people and hopefully enables us to get in early and intervene with pharmacological and lifestyle measures to reduce those complications that we've been hearing about, and also the progression onto further stages. So people who should be screened include those with risk factors for CKD, and there's a list there which we're probably all familiar with. You know, unsurprisingly, we've got diabetes and hypertension there, people with a positive family history or structural problems. I do want to draw your attention to screening other people, such as those who you incidentally find for some reason have a reduced renal function under 60. So that should prompt an ACR check, or people who you notice actually on ACR check have proteinuria more than 3 milligrams. And even people who have persistent hematuria. And I think the recommendation is if you find hematuria on 2 out of 3 urine dipsticks, that's consecutive testing, provided they don't have a UTI, and obviously malignancy has been ruled out, we should also be screening for CKD as well. Screening is very simple. I've put on some pictures there just to reiterate the point. It's a blood test looking at the EGFR and coupling this with an preferably early morning urine sample test to look at the albumin creatinine ratio. Next slide, please. So it's all very well doing the screening and diagnosing, but I did make the point in Tier 2 as well that the London Kidney Network have highlighted that there is a discrepancy in the coding. So it's important that we are coding them, and please be using the new classification, which includes the EGFR and the proteinuria stage as well. Next slide, please. And the reason it's important to make sure we look at both is it helps plan our management. And Manpreet went through about when to refer, but I quite like this heat map which I've got on there, because actually it labels refer, monitor, and I tend to use that as a good guide as well to help me decide what I'm going to be doing next. Next slide, please. So moving on to involving the multidisciplinary team and the wider team in managing patients who've got a confirmed diagnosis. Sandeep kindly took us through quite a few case studies about medical management. And you can see that medical management includes looking at underlying causes, checking for disease progression, managing the risk of cardiovascular disease. But the other column on the right-hand side also talks about ensuring we're doing appropriate medication reviews, giving appropriate lifestyle advice, managing any mental health complications as well. And this slide is really a summary of the NICE guidance of steps needed for the holistic management of patients once a confirmed diagnosis of CKD has been made. And I think this is really where involving the R's roles or members of the multi-professional team can be very helpful. Next slide, please. So if we think about the clinical pharmacists that we have in our practices, it's an obvious thing to ask them perhaps to have a look at medication changes. I've listed a few things there about what a medication review would involve. So assessing current medications, optimizing dosing for blood pressure, diabetes, thinking about the statin, which Sandeep talked about, Manpreet too, and also thinking about the antiplatelet medication. There is one drug I've missed off there. I don't know if anyone can think about, oh, there's a big drug that's missed off that list. If anyone wants to have a guess in the chat, something else that we should immediately start thinking of now. Some new guidance that's come out. We talked about it quite a bit as well earlier. But not to worry, what I'm thinking about really is the SGLT2s, in particular dapagliflozin, which we know is now recommended as an option. And just a reminder, it's not just people who've got type 2 diabetes and CKD, it's people with an albumin creatinine ratio of 22.6 milligrams or more as well. Okay, thank you. Next slide. So this is just really summarizing for us some of the lifestyle and advice that we've been given. And I'm actually going to hand over to Chi to talk more about how the personalised care roles, which include health and wellbeing coaches, social prescribers, can play a role in helping patients make lifestyle changes advocated by NICE. You can see I put a picture there about stopping smoking. You know, smoking is associated with severe proteinuria and progression of CKD. And NICE advocates reducing drinking, leading a healthier lifestyle with a healthy diet, reducing your weight, because actually they've advocated reducing these factors leads to a reduced risk of cardiovascular complications and the risk of CKD progression. So I think I'm going to hand over to G, who can tell us a little bit about how those personalised care roles can aid us with that. Thank you, G.
Thank you. Next slide, please. So I'm actually going to try and whiz through these in the interest of time. I think I've talked about the role of personalised care in supporting self-supported management. We know that stress is a major contributor to health deterioration, and the personalised care team actually has time to explore the other determinants of health, things like physical exercise, the emotional well-being, financial situations, their social aspects, occupational, even spiritual, and the environmental. So really we're looking at transforming conversations to what is the matter with you, where clinicians are taking care of their health, to what really matters to you. So we're getting underneath the skin of the problem. Next slide, please. This is just to illustrate that we do work as a team, so the social prescribers, health and wellbeing coaches, care coordinators, mental health practitioners. Really, the way I like to see it is that we hug a patient and we come in from all four angles with all our specialists' experience to support and facilitate what really matters to that patient. Next slide, please. There's an in-depth explanation. Just want to reiterate that the referrals we get aren't really disease specific or symptom related. Hence, the team will only be looking at other factors that contribute to a person's well-being. But I will speak about a case regarding long-term conditions. Next slide, please. These are just some of the patient experience which really matter to us, and what it shows us that the support that we provide patients really does add value, and it's the small, simplest changes to the environment or to their lifestyle that does make a great difference to the impact of the quality of life. Next slide, please. Okay, so managing, I've put long-term conditions, and this is more of an MDT approach. So here's an example of an elderly person in her 70s, or early 70s anyway. We often see them with mental health conditions, so early onset dementia. They may be clinically stable on the medication, but they require regular ongoing support. Some of the patients that come and see us describe their situation as a personal earthquake. It's almost as though their life is falling apart because they feel that they've lost control, or they're not quite sure what their diagnosis, their disease diagnosis means in the long term. And here's a story about a lady in her 70s with multiple long-term conditions. She's referred to the social prescribing team with recently exacerbated symptoms that were being caretaken by the clinical team, but she had early onset dementia. Once we started getting underneath the symptoms, we discovered that she'd recently lost her mother. She'd been a carer for her for the last 30 years. And although they were living in a comfortable home, within 3 months, she actually lost her home, lost all her belongings, and she was put in sheltered accommodation. She was in one tiny little room. It was really awful. We actually went and paid her a home visit due to a language barrier. She didn't have a mobile phone. She only had a landline there. She felt displaced, disorientated, and disconnected from her community and her friends. And within those 9 months, her health had drastically deteriorated. And what really mattered to her was to be close to her community, to be able to go for a meal with her friends and feel reconnected. So we got the housing team involved. They actually attended the MDTs that we have on a regular basis. We put some safeguarding in place for her. Social services got involved. We arranged some mobility travel for her because mobility had been compromised, and connected her to some local networks. But at the moment, we're still in discussion about rehoming her close to where she was. There's kind of like a 5-mile difference, which is quite a lot for an elderly person. And really, it was her inability to manage that sudden change that literally happened overnight that had contributed to her health deterioration, which really raises the question, you know, when we're looking at a patient and the circumstances they're in, sometimes we can actually prevent health deterioration by just taking a little bit of time to see what that person's needs are at that time, and ensure that if we are allocating them to a new house or a home or rehoming them, to make sure that the rest of their community connection isn't disturbed. So yeah, this is just an example of what we do behind the scenes. Thank you.
Thank you very much, everybody. Are there any questions? Please do ask them. Please, before you leave, I know it's time. Please, could you just take a moment to complete a questionnaire, and you will get a certificate of attendance for this Tier 3 webinar. And it's essentially multiple choice and talking about how you felt and what you felt that you learned. So let me just pull it up. Okay. Here it is. Thank you all so much for coming once again. We hope to see you at future webinars. There's going to be the Cancer Tier 1, Tier 2 cohort webinar on Tuesday 30th, led by Dr. Bumi Olajide, Jyoti Sood, and Sangeeta. And there will also be Jiga here joining us. So please just take one moment. It'll be no more than 10 seconds. I've made it even shorter than before. And once again, it's just multiple choice. The only writing you have to do is your name. I will stop recording.
Whereabouts is